A very good evening to all of you. So yet again with the dawn of ENT, Professor Anthony, and today we are going to have grand rounds. The idea of grand rounds, as you know, is actually like a mock exam. It's going to be similar to how you're going to face your Viva after your MS or your DLO or your DNB. And Professor Anthony has been kind enough and he has agreed to conduct mock exams. There's one change which I want to announce. Next week, instead of the 27th, we'll have it on the 28th. There is just one change. Harsha, please note this. Instead of 27th, Harsha is there?
Yes, sir, I'm here.
We'll be doing it on 28th. So we'll have to change it by one day. So today we are going to have a case of larynx, CA larynx. You would have attended many such rounds by many colleges, but believe me, I can put my hands down and say you are going to listen to the authority in larynx. I know because I've been seeing Professor Anthony from he was my UG classmate and also PG classmate, and during his PG we all used to read Scott Brown. So we used to read Scott Brown and go, but he was one PG who used to read Batsakis, Eugene Mayers, and Scott Brown. I think for every thing like radiotherapy has got a book like that. He used to read one book for all the books. He used to verbatim say Paparella also. He used to say Paparella. One PG was very well read. Believe me, I will not flatter anybody. I don't want to at this age. I don't have to. And he also doesn't need anything like that. But since I know him personally, I'm telling this. From his PG days, he has been a perfect, thorough academician. And today he's going to interview Dr. Aishwarya, who is a third year MS postgraduate in Madras Medical College. I'm proud to say I'm also from MMC, and Professor Anthony also is from MMC. And she's going to present a case of CA larynx. And without much ado, over to the dawn of ENT, Professor Anthony.
Thank you, Janagram, for your kind words. Yes, I am very happy to say that I'm your long-time friend, maybe one of the longest friends we were, and we were together for a long time. You were with me on all my first, and I was with you on all your first. Like I still remember our first total laryngectomy and first maxectomies and things like that. Thank you very much for being with me.
That when we used to do, I used to have 4-bedded nursing home called Trichy ENT Research Center. I started at the very early age, at around 29, something like that. And whenever I used to do a case of CA larynx, any major case, I used to call Professor Anthony, and Professor Anthony used to come all the way from Chennai, and we used to have a gala time after the case till night, 1 o'clock, 2 o'clock, 3 o'clock, nicely chat about our college days, and then he used to go back. Those were
that is the gala time.
Golden days.
That is the gala time. Chatting about college days. Yeah. Yes, and I have to congratulate Aishwarya for presenting this, and she has recently 10-15 days back she has delivered a baby, and congratulations, Aishwarya. And with that, she is eager enough to present the case, and she is going for exams. So congratulations, Aishwarya. All the best. Start presenting your case.
Good evening, everyone. I'm going to be presenting a case of CA larynx. So, a 65-year-old male, Mr. Soundra Pandian from Kanjipuram, working as a farmer, has come with a chief complaint of voice change for the past 1 year and difficulty in breathing for the past 1 month. So, history of presenting illness. The patient was apparently normal 1 year back, after which he developed the complaint of voice change. Hoarseness of voice, which is insidious in
voice change can be addressed as dysphonia, right? but hoarseness is a characteristic voice. How do you define hoarseness?
So, harsh voice, which is not characteristic of the particular age or sex.
So, a harsh, discordant voice, which is not characteristic of patient's age, sex, or character, is called hoarseness. Female talking like a male is hoarseness, and the change of original voice become harsh is hoarseness. Usually, it is because of two things. One is the increase the thickness of the vocal cord or cross section of the vocal cord, and second one is due to the functional inability of the superficial layer of lamina papyracea to move easily over the intermediate and deep layer, right? Hoarseness of voice, right? Present.
So, which was insidious in onset and gradually progressive in nature. There is no aggravating or relieving factor. So, complaints
Wait. Whenever you think of this for change of voice or think of hoarseness, see, usually hoarseness comes for every upper respiratory tract infection. When will you think the hoarseness is significant so that you got to evaluate the patient?
when it is progressive, sir, and also
duration.
no relieving factor.
Duration.
More than 3 weeks.
More than 3 weeks, it got to be evaluated, right? There are a lot of factors which are all called the danger factors in the hoarseness. What are all they? When the hoarseness is progressive, it's not remitting. Second one is the intermediate time when the pain increases with the hoarseness, which is a sign of non-remitting hoarseness. Third is associated dysphagia. Fourth is associated neck swellings. Fifth is associated aspiration. So sixth is associated, it occurs in smokers, occurs in alcoholics, occurs in the people who are exposed to the pollutant which is known to produce malignancies. So all these things are all risk factors. So whenever you see a patient who has got a hoarseness, along with that patient have an odonophagia, along with that patient have got a dysphagia, loss of weight, is an alcoholic, is a smoker, all these things are all danger points in a patient of a hoarseness. So keep this in your mind that whenever you present a case of hoarseness, all these things got to be presented at the approximate places. Okay. So when you have a giddiness, we take certain things as a red flag signs. Like whenever there is a giddiness with the headache, giddiness with the false localizing signs, or nausea and vomiting, or progressive giddiness, we think there is any intracranial problem. Similarly, whenever you see an hoarseness with all the following things, you got to always think of patient can have a sinister diseases. It's not because of chronic laryngitis or because of a vocal polyp. Okay, right.
Complaints of difficulty in breathing for the past 1 month, insidious in onset and gradually progressive in nature, aggravated by physical activity, relieved by rest. It is not associated with noisy breathing.
Okay.
So no history of difficulty in swallowing, no history of sore throat or throat pain, no history of foreign body sensation in throat, no history of aspiration, no history of ear pain, no history of neck swelling.
So these are all the things: history of aspiration, history of ear pain, history of neck swellings. All these things are danger signs. Okay, so you got to keep those in your mind. Can you go to the previous slide? The no history of difficulty in swallowing. Okay, so when the patient has got a difficulty in swallowing, what do you think of? This patient, when you don't have a difficulty in swallowing, you pinpoint a patient to one particular area. Okay, we'll see to that later. Proceed.
No history of ear discharge, hard of hearing, dizziness or ringing sensation in ear. No history of nasal obstruction, nasal discharge, headache, facial pain or postnasal drip, or bleeding from nose, or no history of trauma. There was history of loss of weight for the past 1 month and history of loss of appetite for the past 1 month.
Okay. Okay.
So past history, sir. Patient is not a known diabetic, known hypertensive for the past 3 years, and he's not a known tuberculosis, bronchial asthma, or epileptic patient. History of previous surgery for hydrocele 21 years back. No history of any bleeding disorder, previous blood transfusion or drug allergy.
Okay.
Personal history, mixed diet, patient takes mixed diet. He's a known smoker for the past 40 years, average 10 BDs per day, known alcoholic for the past 40 years, normal bowel and bladder habits.
When you call a
Family,
patient alcoholic, how much amount of alcohol taken per day is called as alcoholic? Then they will ask you what are all the percentage of alcohol in various drinks. They'll ask you what drink he takes. So how much amount? So or what is the percentage? So whiskey, brandy, rum. So all these things contains a certain percentage of alcohol content. And then beer and arak has got a different percentage of alcohol content. So when you call a patient an alcoholic?
sir, when he takes more than 180 ml per.
So no, it's not comes like that. When the patient have an habit of taking urge to take alcohol every day, and a person who takes alcohol even if he is alone is taken as an alcoholic. It's not a social drink. Okay, so approximately it takes about more than 90 ml of 90 ml of standard alcohol per day is called is an alcoholic. Okay, then.
So family history, no other family history of any CA, nil significant. Family history nil significant.
Okay. So you think where the lesion is?
Sir, glottis.
Why
But,
glottis?
there is the presenting complaint is change in voice, sir.
Okay. So a person who gets main presenting complaint is change of voice. Usually it got to be in the larynx. Okay. Why it's not a supraglottic?
So a patient may have a foreign body sensation.
There will be a foreign body sensation. Second thing is can have dysphagia. The patient can have a soreness, rawness of the throat, and neck swellings. These are all common. Okay, but the neck swelling is very not reasonably common in the glottic region. Which region that CA larynx is common?
Sir, glottis.
What is the percentage? Rule of 8. 80% glottis, 8% subglottis, 35 to 40% is supraglottis. Okay, so commonest thing is glottis. What is the patient doesn't have a neck nodes. When the patient doesn't have neck nodes, most probably the disease is from the glottis, because only 4% of the glottis growth patient will have a neck node compared with that of the other areas, where 40%, 38 to 40% will be your supraglottic tumor, and 14% will be your subglottic tumors. Okay. That is then that's another reason. So the patient who has got a disease of disease of change of voice, who don't have any other disease like any other disease, any other symptom like difficulty in swallowing, pain during swallowing, or neck swelling, and then so this is the patient will have a usually laryngeal tumor, probably at the level of the glottis. Okay, why the patient has got a difficulty in breathing?
So patient may go in for compromised airways, sir.
Then patient should have had a stridor. He said no noisy breathing. We keep this in your mind. Maybe because of secondary lung. It can be because of aspiration pneumonitis or silent aspiration. So it can be because of unrelated other causes like cardiac causes or chest causes. So you keep that in your mind, and most probably there may be extension into the it's early cases of case of stridor where you don't hear the noise, but you can feel the noise. That we'll take it up when you're going to examine the patient. Okay, so you have a disease. Most probably it's a progressive disease. Most probably it's a malignant disease arising from the larynx, probably at the level of the glottis. That will be um, uh, your idea about this disease. Okay, continue.
General examination. Patient is conscious oriented, moderately built and moderately nourished. No pilar, not icteric. Clubbing was present.
You think patient is moderately nourished? I have not seen the patient, but you say the patient has got a loss of weight for about 1 month's duration. So what is built? What is nourishment?
Nourishment is amount of subcutaneous fat, sir.
That is, nourishment is the short term. It's short term well-being. Built is long term well-being. The patient who is not taking proper nutrient for a long time from the childhood, that build will be smaller. Patient who has lost weight recently, they will have a poorly nourished. So that you got to check it up again. Okay, right then.
No pedal edema, no generalized lymphadenopathy. So
what else you should? Okay, right.
Vitals, pulse rate was 86 per minute, BP was 130/80, saturation was 98% at room air.
Okay.
Examination of throat, examination of oral cavity, upper lip, lower lip.
Go to the hypopharynx larynx. Yeah, indirect larynx examination. Okay.
Posterior 1/3 of tongue was normal. Bilateral pharyngoepiglottic fold, median glossoepiglottic fold were normal. Epiglottis normal. Bilateral aryepiglottic fold normal. Right arytenoid was normal. Left arytenoid has impaired mobility. So right false chord normal. Left false chord had impaired mobility. True chords, left true chord, pink irregular proliferative growth, visualized involving the entire length of left chord, involving anterior commissure and also extending till anterior 2/3 of right vocal cord with impaired mobility on the left side. So left.
Again, you are sure it's an impaired mobility or it's not mobile?
Not mobile.
Why impaired mobility? Okay. When do you call a patient who got an hemilarynxis, and when do you call a patient as the when do you call the patient as left chord is fixed?
Sir, when the arytenoids and AE fold, false chord and true chords are fixed, we call it hemilarynx fixity.
Okay. You sure that left vocal cord, left false chord, there is no bulge? Okay.
So left AE fold and arytenoid were removed.
You see this. You see the left ventricular band. It's little pushed up. Okay.
So irregular growth involving entire length of the left vocal cord and anterior 1/3 of the right vocal cord involving anterior commissures. Left hemilarynx is fixed.
Okay.
Glottic chink was adequate, sir.
What is rhinoglottis? What is glottic chink?
Space between the
airway between the two vocal cords is called glottic chink, and the edge of the vocal cord is called rhinoglottis. Okay, right. Then present.
So examination of neck. Laryngeal contour was normal. Crepitus was normal. No tenderness. Airway adequate. Patient not in stridor. Trachea midline and no palpable lymph node was seen.
Trachea. Did you palpate for stridor?
Yes, sir.
Was the patient having stridor?
No, sir. No, sir.
No tracheal thrill. You should palpate all these patients with your finger, thumb, and then you got to use your steth and look for and should hear for the thrill. Okay, the mildest form of vibrating air column will be felt or it will be heard with your stethoscope on the trachea. Only if it becomes bigger, you get the stridor. Okay, that you should have done. Next.
Examination was examination of ear was normal.
Ear knows anything significant?
No, sir.
No. Right. Then.
And systemic examination, cardiovascular system, S1, S2 present. RS bilateral breath sounds equal, no added sounds. Parabdomen, no hepatosplenomegaly or any organomegaly. CNS, no focal neurological deficit, and spine and skull normal.
Okay. What's your diagnosis?
Malignant growth larynx, subsite glottis, stage T3, N0, N0.
Clinical stage 3. Clinically, it is stage 3.
Stage 3.
Clinically, stage 3. I mean, clinically, T3. Okay, right, fine. Why do you say it's a malignant growth?
Sir, because the symptoms are progressive and non-remitting. Etiological factor of smoking and alcohol was present.
Listen. You are sitting on an exam. All your examiners are all old. Most of your examiners smoke and take alcohol. So you go tell this first to them, they'll get offended. They will come and ask you, I am old, I am 50 plus, I take alcohol, I smoke. Do you mean to say I get malignancy? But the sad truth is that if somebody comes and asks you on the road, you will say, you idiot, if you smoke, you will take alcohol, you will get malignancy, but you can't tell that in an exam. Right? So don't tell these things at all as the first point. In an examination, the patient can bluff. Patient can tell lies to you. So what is more important? What do you see? So first thing you see, the signs of malignancy in a tumor is you see the surface of the tumor. It's a proliferative irregular tumor with the everted margin extending along the facial plane from one cord to the opposite cord involving an anterior commissure. Okay, and a deeper infiltration with vocal cord fixity. So a fixed cord always says there is a deeper infiltration. An infiltrative lesion is the malignancy. A tumor appearance. It's a proliferative. Actually, you see that surface, it is little warty. Warty hyperkeratosis proliferative growth involving the entire length of the vocal cord with a mild bulge on the left vestibular vestibular folds, go to an anterior curvature and come to the opposite cord. And with a deeper infiltration, muscular infiltration causing vocal cord fixity. Okay, so if you see a tumor like this, you always say this is the malignant tumor. And then it has got a symptoms, 1 year unremitting symptoms with the loss of weight, loss of appetite, and then patient is having it occurs on a patient who's elderly, who smokes and takes alcohol for long duration. Is most probably it's a malignant tumor. So how will you confirm this malignancy?
So, a microlaryngeal examination and biopsy.
Do microlaryngeal examination straight away. Will you do it straight away or do any other investigation before that?
So the routine blood investigations.
Nothing is routine in exam. So you do total count, differential count.
Differential count,
differential count,
renal function
hemoglobin.
test.
Okay.
A liver function test, sir. And
See, this
Xray
patient,
neck.
X-ray. Okay, you want to take X-ray neck. Okay. What view you want to take?
Both AP lateral, AP and lateral.
AP lateral. What way it is important? What can you see on X-ray neck?
Sir, extent of lesion, sir. Airway, whether it is adequate or not.
Okay, this
And
patient has got a
deviation of
difficulty.
trachea.
This patient has got a difficulty in breathing. So this patient might require tracheostomy in recent future, particularly if the patient develops stridor. So you want to know the lower extent of the disease can be found out by the X-ray, and also by the you want to see the tracheal position. Okay, and associated second primary. For this, X-ray is important. What other X-ray you will take?
So the X-ray chest, sir, to look for any metastasis.
X-ray chest. So you can do, but nowadays we don't take these X-rays. Instead, we go for the CT scan, CT neck, and the and the chest. Why you want to image the chest?
To look for any metastasis, sir, and also associated any COPD associated with since the patient is a chronic smoker, so pulmonary function may be compromised. So for that purpose, we are taking it.
Okay, X-ray chest, X-ray imaging the X-ray is taken is a pilot examination, because you are going to treat the patient for a long time. The patient might develop anything. He can develop another shadow in future. So you want to just check it whether that shadow is before there or not. So for that, you got to take you got to image the chest. It's called a pilot film. So the CECT neck and this is the pilot film. Even your microlaryngeal examination got to be recorded. Okay, these are all pilot studies, because if you see a small tumor, which you think it's only a benign tumor, you take biopsy. Once you take biopsy, excise it completely and send for biopsy, and biopsy comes as squamous cell carcinoma. What will you do? There is a scenario. You do a microlaryngeal examination. You see a mid-third vocal cord, there is some polypoidal growth. You take biopsy. Once you take the biopsy, biopsy report came as the squamous cell carcinoma. What will you do?
Sir, if the margins are clear, I'll follow up the patient, sir, or else RT radiotherapy.
No, the thing is, how will you follow up the case?
So
will you do any imaging?
CCT.
Why? What for?
Sir,
very small lesion. It's only on the vocal cord. Medial surface looks like a benign tumor. You cannot see. Mucosal diseases, you got to keep that in your mind, is diagnosed only with your examination, maybe a direct examination or an indirect examination, not by your X-rays, not by your images. Images are all used only for the deeper penetration. Major are used only for the deeper penetration. But the idea is before treating a treatment for this patient, everything got to be recorded. Everything got to be recorded. That is very, very important. So this is the recording of the image of the chest. So that is the pilot examination. Second is to rule out the secondaries. Third is second primary. Fourth is mediastinal extension, mediastinal nodes. Fifth is to see the aspiration pneumonitis. Okay, so pilot film, secondaries, second primaries. 5% of the head and neck malignancies are always associated with the second primaries. Okay, then cardiac anesthetic purpose, cardiac evaluation, chest evaluation. All these patients have got a associate because of the poor nutrition. Patient can have an associated COPD, or patient can have a cavitatory lesion in the lung. So the cavitatory lesion can have inside that the cavitatory lesion because of an immunocompromisation. Patient can have a fungal ball. All these things can be diagnosed with your imaging. Okay, so first thing is pilot film. Second is secondaries. Third is second primary. Fourth is any mediastinal lymph nodes, aspiration pneumonitis. Then you look for cardiac assessment. Look for lung assessment. Look for COPD or associated tuberculosis. There is a cavity inside that cavity. And recently, with with an advent of COVID, it will give you an idea about the COVID score also. Okay, so all these things are advantages of chest screening. Then CT neck. What CT you will take?
CT neck.
CT neck, multi-direction, multi-planar CT. What are all things you will look for?
Extent of lesion, sir. Whether it is extending to paraglotic space and pre-epiglottic space, whether it is extending to subglottis, and neck nodal status, sir.
Okay. Cartilage invasion. Okay, so important for three things. One is for the deeper invasion like cartilage invasion. Second is for the geography of the tumor, where are all the tumor is spread into the paraglotic space, arytenoid cartilage, subglottic area, ventricle, false vocal cord, all these areas you can see. Third is the neck nodes. How does the node look like on a CT scan? How will you differentiate a benign node from a malignant node?
Sir, round in shape, sir. Whether a reactive node is elliptical in shape, and loss of fatty hilum and increased cortical echoes. Sometimes calcification may be present, and
extracapsular spread.
surface.
Extrascapular spread causing irregular surfaces. These are all the important points to differentiate a node from the size. The node usually about 1 millimeter, 1 centimeter in size, and except in the jugular digastric, where the jugular digastric it will be 1.5 centimeter. If it is more than that, it is a significant node. Okay, so you do the CECT. Okay, then what else you do? Any other investigation you do?
The pulmonary function test.
Will you do an MRI? Will you do an MRI?
Yes, sir.
Why? Better evaluation of the nodal status, cartilage invasion, and the extent of the tumor, because it's a soft tissue tumor only. So this can be seen better. Any other test you do?
PET scan.
Only PET or PET CT?
PET CT.
PET CT is for the complete evaluation of the meds. Okay, always you do a PET CT. Doppler and neck examination with the uh, with the ultrasound is of not much use, particularly in the case of a CA larynx. Okay, you do a stroboscopy. Stroboscopy is of no use when you see such a big tumor like this. When the stroboscopy is useful is when you have a very small tumor, you don't know whether it's a benign tumor or a malignant tumor. Benign diseases that doesn't invade the intermediate layer. The malignant tumor invades intermediate and the deep layers of lamina propria. So when you do a stroboscopy, you look for the wave pattern. When the wave pattern is absent, or wave pattern is impaired, you will think it is a deeper invading tumor. The deeper invading tumor can produce, it can be due to a malignancy. Okay, that is stroboscopy. Anything else you do? There are a lot of things you will do, a lot of things we read. We read like we start doing video laryngoscopy, then you do a sort of stroboscopy. And then most of the things what we read is not available in India, like video chymography, optical coherent tomography, and then you have things like sort of NDA. NBA is a useful, this thing is all for the screening purpose or to take out the smaller lesion to see whether it is benign or malignant. NBA, you look for vasculature. It is assumed that a malignant tumor gets a lot of neovascularization, so you get a lot of blood vessels. But that will give you an idea. They said it is as correct as it of a 98% of the sensitivity. But the problem is, can you going to do a radical surgery on a patient seeing on only on MBA? It can be used as a screening tool to take biopsy, but it's not a foolproof. Okay, that's what I told you now. Okay, then second thing is contact endoscopy and confocal endoscopies are all used. Okay, it can be used, but all is nothing is a replacement for DL-scopy biopsy. I mean, microlaryngeal examination and biopsy. Okay, before that you got to rule out the second primary. Those days we used to take a barium swallow. Okay, barium swallow, one of the important things of barium swallow is you can see from the side the mobility of the larynx, particularly in the hypopharyngeal growth. Whenever there is a prevertebral infiltration, larynx will not move. When the larynx don't move, that's the case you should not operate, because prevertebral invasion is the contraindication to do a radical surgery. So second thing is you can look for second primary, lower extent of the tumor if it's an hypopharyngeal tumor. Mainly in the case of a CA larynx, barium swallow is done to rule out second primary. Similarly, you do a triple endoscopy, you do a bronchoscopy, esophagoscopy, and this thing. All these things are all to rule out second primary, which can be taken out by a one investigation, that is PET-CT. Do a PET-CT. All these things are all need not be done. Okay. When you do a microlaryngeal examination, what are all things you will look for? Microlaryngeal examination is not to take biopsy alone. Microlaryngeal examination is done to see the tumor, map the tumor. Whatever imaging you see, if you think there's a tumor has got a lateral extension, it got a subglottic extension, you can retract the tumor and see how far it has gone up, how far it has gone anteriorly, whether anterior commissure is involved or not. All these things you can see. Okay, then you can palpate the tumor. You see whether the tumor is firm or it is very hard. The hard tumors will have a poor blood supply, and these poor blood supply tumor will not respond much for a radiotherapy. Then you can take biopsy. Biopsy can be taken geographically from the margin, from the center of the tumor, various places. See two lobules, you can take from two lobules and label all these things. So all these things cannot be done when you do a office biopsy procedures. Even though if you do an office biopsy procedures, video laryngoscopic biopsies, it's always safe to do a microlaryngeal examination under general anesthesia. Okay, then you see the mobility of the cord. You see whether the probe test for cricoid joint involvement. All these things can be done with the microlaryngeal examination. Okay, so once you are done, you will know what is the staging of the tumor, what is the plan. Okay, this tumor is an advanced tumor. What do you think this tumor? How does the CA larynx spreads? Where does the glottic tumor starts?
Vocal cords. Squamous epithelium. Vocal cords.
Vocal cord and the lamina propria. Okay, the tumor spreads along the superficial layer of lamina propria from the mid cord to the anterior commissure and to the vocal process. Once it goes to the vocal process, see, there are a lot of barriers called anatomical barriers, embryological barriers, and the mechanical barriers, and also chemical barriers. So, the both vocal cords takes separately and comes to the midline. Why vocal cord is the common area for malignancy is there is a squamocolumnar junction at two areas. Okay, one is anteriorly, other one is posteriorly. I mean, one is laterally, other one is medially. So supraglottis has got a pseudocytic ciliated columnar. Subglottis has got a pseudocytic ciliated columnar. Joining area, you will have the squamocolumnar junction, which is vulnerable for malignant formation. So where does the malignancy start? Starts in the area called Rinky space. What are the boundaries of Rinky space?
The anterior, superiorly superior arcuate line, inferiorly inferior arcuate line, anterior commissure and posterior commissure.
Anteriorly anterior commissure, posteriorly posterior commissure, or vocal process. Okay. So what is the medial boundary, lateral boundary?
Medial boundary is the
free border of vocal cord. Lateral boundary is by the vocalis muscle. Okay. How do you get a superior boundary and an inferior boundary? At the same time, you get a medial and lateral boundary.
movement of vocal cords. When the vocal cords are in abducted position, in superior and inferior arcuate lines.
See, when a vocal cord closes in midline like this, when it closes in midline like this, you have a medial boundary, lateral boundary. But when the vocal cord goes laterally, it goes like this. So you have a superior boundary and inferior boundary. Superior boundary is a superior arcuate line, inferior boundary is an inferior arcuate line. Superior arcuate line is the junction of the beginning of ventricle, lower border of ventricle to the vocal cord. Inferior arcuate line is the medial border which goes laterally like that. So it's a submucosal space which contains loose areolar tissue. It's called superficial layer of lamina propria. It's anteriorly go to anterior commissure, posteriorly goes to the vocal process, medially free border, laterally the vocalis muscle. It's a submucosal space where the tumor enters first. From there, it spreads easily because no resistance to anteriorly and posteriorly. Once it goes deeper, it involves the ligament and the set of musculature. It prevents the vocal cord free movements under mucosal wave pattern. So this is called the fixity. What are the causes of fixity of the vocal cord?
It may be due to tumor bulk, infiltration of thyroarytenoid muscle, or infiltration of recurrent laryngeal.
Or it may be because of the fixity of the vocal cord. Okay. I mean, sorry, fixity of the cricoid joint. Okay. So, if it goes to an anterior commissure, it got stops by the Broyles ligament. So Broyles ligaments prevent it to spread to the opposite cord. But the problem with the Broyles ligament is the closest attachment to the cartilage is there is a devoid of perichondrium. Perichondrium is the good barrier for the tumor prevention of tumor spread. The insertion area, that is the blood vessels goes inside that cartilage. Blood vessels goes inside, and there is a devoid of perichondrium. So it can easily spread to the anterior commissure. Whenever the tumors go to the anterior commissure, it can spread about 1 centimeter about towards the petiole of epiglottis, and also to the subglottic area, where the tumor can become a supraglottic, glottic, and subglottic. So all the anterior commissure tumor involves all three areas. So it got to be carefully staged as tumor staged. Okay. Similarly, once it goes to there, whenever the cartilage is ossified, that can easily it can get involved. It can got eroded. So the cartilage invasion will cause perichondrium can get infected, can become patient can develop perichondritis, or even patient can develop tenderness. Okay, so once it involves the petiole of epiglottis, you got to be careful about the there will be a lot of pits in the infrahyoid part of epiglottis, which can transmit the tumor to the pre-epiglottic space. What are all the boundaries of pre-epiglottic space?
So superiorly, hyoepiglottic ligament, inferiorly thyroepiglottic ligament, posteriorly the infrahyoid epiglottis, and it communicates laterally with the paraglottic space, and inferiorly thyrohyoid membrane.
Superiorly, you get the hyoepiglotticus ligament. Okay. Posteriorly, infrahyoid part of the epiglottis. Anteriorly, by the thyroid membrane and the part of thyroid cartilage. Laterally, it communicates with the paraglottic space. Okay. So this contains the fat. Particularly whenever there's a supraglottic tumor, the tumor can easily go inside the pre-epiglottic space. When there, it goes to the paraglottic space and becomes hemilaryngeal growth. So yeah, whenever the pre-epiglottis is involved, you can't leave you can't treat the patient segmentally. You want to treat the patient as the whole laryngeal involvement. Okay, what are the boundaries of paraglottic space?
Medially quadrangular membrane, conus elasticus, and it encircles the ventricle. Laterally, thyroid cartilage and thyrohyoid membrane, and superiorly, it extends from the pharyngoepiglottic fold and mucosa covering the vallicula.
No. Mucosa covering vallicula is not the superior boundary. Superiorly by the area epiglottic fold. Superiorly area epiglottic fold. Medially, quadrangular membrane, ventricle, and conus elasticus. The ventricle invades into the paraglottic space. Laterally by the thyroid membrane and the thyroid cartilage. Okay, so so this is the posteriorly anterior reflection of the pyriform fossa. This is the if you take a pin and prick the vallicula from above, where it goes inside is the pre-epiglottic space. Similarly, you take the pin and prick the pyriform fossa, where the pin goes inside is the paraglottic space. Okay, so three important spaces: space of Boyer and Tucker, which is the pre-epiglottic and the paraglottic space, and then you have the Rinky space. Okay, so what is the transglottic tumor?
So, tumor which traverses the ventricle, which involves the paraglottic space, which involves the anterior commissure.
So the tumor which travels from the supraglottic to glottis or glottic to supraglottis is called the transglottic tumor. Usually these tumors fill the, because it is close to the ventricle, it will go inside the paraglottic space early and fix the vocal cord early. When you look at when you do and they have a neck metastasis early. And when you look inside, the tumor will, the patient will not, there'll be a bulge on the ventricle. Like this patient, what you have shown, there's a bulge on the left ventricular band. That is because of filling of the paraglottic space. So this, if there is a tumor primarily in the paraglottic space area, you don't even see the tumor outside well, but you'll have an early vocal cord fixation because of the vocalist muscle infiltration. So a tumor which traverses the ventricle, which involves supraglottis, glottis, and known to involve all three areas, filling the going to the paraglottic space early, fixing the vocal cord early, and can have an aggressive tumor which can have a neck metastasis is called the paraglottic tumor. It doesn't matter where the tumor starts from. It can usually, as you know, the commonest tumors are all the glottic tumors. So a glottic tumor can go to the glottic tumor can go to the supraglottis. If you see the tumor in your indirect laryngoscopy examination, most probably that's a glottic tumor. If you don't see the tumor, it's most probably it's a supraglottic tumor which is coming to the glottic area. Okay. So how do you state the how do you see the TNM classification of this patient?
This patient, it is T3, sir. T1 is involvement of vocal cord with a normal vocal cord mobility. T1A is involvement of one vocal cord. T1B is involvement of both vocal cord with or without involvement of anterior commission. T2 is lesion involving extending to supraglottis or subglottis with impaired vocal cord mobility. So T3 is lesion limited to larynx with spread to paraglottic space, inner perichondrium of thyroid cartilage with the hemilarynx fixity. T4A is when the disease extends to the locally moderately advanced local disease. So the lesion extends to
early advanced disease. It's called now as early advanced disease. T4A is early advanced disease. Extralaryngeal spread, cartilage invasion, thyroid cartilage invasion, cricoid cartilage invasion coming out to the neck. How does the tumor comes outside? Where does the tumor fixes the recurrent laryngeal nerve? What is cricothyroid triangle?
Through the cricothyroid membrane, the tumor goes.
Cricothyroid membrane, cricothyroid muscle, and the thyroid cortex forms a triangle called a cricothyroid triangle. That's the weakest point through which the tumor comes out. Once the tumor comes out, it infiltrates the recurrent laryngeal nerve before it enters the larynx. Okay. Then when will you call what is T4B?
T4B is when the tumor involves prevertebral fascia, in cases carotid, or
going far away places like tongue goes to the mediastinum, then you call a very advanced tumors. Okay, so what are you going to do to this patient?
Sir, T3 we can go for organ conservation strategies like chemo.
How do you know it is T3?
So the hemilarynx fixity.
Preeti Sharma. Vertical partial laryngectomy. Vocal cord is not fixed. The vocal cord is fixed in the patient. Or it involves both cuts. How do you do a vertical partial laryngectomy? Yeah, you are not sure which is T3 now. Your CT scan will tell you whether there is a cartilage invasion or not. Okay. Varun, no Varun. Total laryngectomy will be done only when you prove that it's an early advance. Okay. So T3 is a controversial. So you can do whether you want to do an organ preservation or organ preservation, or you want to do a radical treatment. If you want to do an organ preservation, you should have the functioning larynx. Okay, so what are the functions of the larynx?
Sir, spindric action, sir. By the three-layer sphincter mechanism, it prevents foreign body entry and aspiration, sir. Cough reflex, chest fixation of chest. It aids in breathing. It aids in circulation by facilitating venous return. It aids in deglutition, mucociliary clearance mechanism, phonation, and emotion.
Emotional phonation, but what you have missed is the conduit.
It acts as a conduit for air passage.
Two important functions. One is the sphincteric function, where anything from above doesn't go inside. What it goes inside your foot pipe doesn't go inside. At the same time, it opens up the airway. It functions as a conduit so that air goes inside and come out. So both the things are all very important. So because air goes and comes, because it closes, you have another additional function called the phonation, which is phylogenetically not so important function. All other functions are all important functions, like fixation, chest fixation, cough reflexes, or other protective reflexes, mucociliary clearance, pulmonary, all these things. So end expiratory pressure is maintained because of the patients who have got a larynx closes. If the larynx doesn't closes, the end expiratory pressure cannot be maintained. If you don't maintain the end expiratory pressure, the peripheral alveoli will not get open. That's why when you do a tracheostomy, there's a possibility of a peripheral collapse and the patient can have a mild pneumonitis. Similarly, whenever there is a inspiration, there is a negative pressure in the thorax and it aids in venous return. So these are all the additional things which is helpful for the life. So when the patient, you do a tracheostomy and the patient doesn't have a functioning larynx, then there is no point in doing an organ preservation. You understand? If the T3 lesion, when your larynx is functioning, there is no tracheostomy, you can go for an organ preservation. If there is already function is lost, you don't think of organ preservation. Even in early advanced cancers, you go for CECT. Okay, early advanced cancers, you can go for a CECT, but early advanced cancers, if there is a, similarly, again, there is you go for chemotherapy, but if there is a laryngeal function already lost, there is no point in going for organ preservation. You can go for a radical surgery. Okay, so what are all the indications for total laryngectomy?
Sir, malignant indication, non-malignant, and miscellaneous. Malignant indication, T4A lesion involving the thyroid cartilage, and lesion involving cricoid cartilage, and the radio recurrent tumors. It can be done as a salvage procedure, and in patients who have with failed initial laryngeal conservation surgeries, we can go for a salvage total laryngectomy. And the patient patient with malignancy who has got compromised laryngeal function, like patient presenting with stridor or aspiration, we can go for a total laryngectomy. And also tumors.
What is the incontinuity? What is the incontinuity resection? When you're doing for a radical surgeries, like when you do a total laryngopharyngectomy, you can't leave behind larynx alone. Or if you're doing a total pharyngectomy, then you got to do, along with it, you got to take the larynx. Okay. Other things are all like the tumors which is not amenable for radiotherapy. radio recurrent tumors, radio residual tumors, tumor which is not amenable for radiotherapy. And when you are planning for some other procedure, for example, you do a bilateral neck dissection. When you do such a huge procedure, along with it, you can remove larynx also. When you're doing a total laryngectomy or any laryngeal surgery which gives that surgical cure, you can do this. Okay, so these are all the indications to do a total laryngectomy. Okay, so and a patient who have got a compromised laryngeal function, chronic aspiration. So these are all the patients whom you do a total laryngectomy. See, assume this patient will think of doing a total laryngectomy, right? What are all the pre-operative workups you will do?
Sir, the pre-anesthetic fitness, for the purpose of anesthetic fitness, cardiac status and echocardiogram, pulmonary function test.
How you do pulmonary function test? You do a tracheostomy to the patient. You have a separate wall for that to do a pulmonary function test. Okay, then what else you do? Psychological assessment, psychiatrist's opinion. These people are bound to go for a severe depression after losing the speech function. Then you send the patient for speech therapy. And then you try to give some soda to the patient, ask them to belch, so that the patient can develop esophageal voice in the post-operative. If they are not fit for that, then you can plan for doing a primary TEP. Okay, these are all, and then you get a dermatologist opinion, you get a dental opinion to rule out focal sepsis. Okay, you got to do the complete liver function test, renal function test, cardiac evaluation, pulmonary evaluation. With all these things done, you got to take the patient for surgery. Okay, and then most important thing is you got to do an informed consent. What is informed consent? You got to realistically talk with the patient about what are all the drawbacks the patient is going to have. Patient can't do a sternus exercises. He would have been a lorry driver. It's very difficult for him to drive a lorry, particularly without oversteering when he has undergo total laryngectomy. The chance for foreign body going inside, chances for drowning, chances for him to not able to take normal head bath and normal physical activities. Okay, so all these things you got to sit with the patient, talk and make him understand. And the family also need to understand these requirements now. The recent situation. Once you have done all these things, you can take up the patient for surgery. Long time back, when we know we were operating on a patient, when I was a postgraduate, we were operating on a patient. That patient was somewhere from Orissa, and he doesn't know that local language. So we were talking in English only with his son and family members. So we have counseled them well and under surgery. After that surgery, when he just got up, the first question he asked is, when will I talk? So you got to talk with the patient on his local language, the language what he understands, not in our language or not in English. When the patient don't understand, it's always very troublesome. Okay, so then in the previous days, what are all things you will check? Your checklist, what are all things you will check for? Check for? I think the people who just come from bigger hospitals or the people who always do cases, total laryngectomies, it's a sort of routine for them. For the people who do occasionally the total laryngectomies, because in the very small colleges and small district headquarters hospitals, you should have a checklist. You should have a biopsy report in the front page. You should have a blood report. I mean, blood grouping and typing. Then you should check for the Ryle's tube, Foley's catheter. Check for whether you have a cuffed endotracheal tube. Okay, and then flexometallic tube for endotracheal intubation. If you do a tracheostomy, you have another flexometallic tube. All these things you should keep ready. Then only you should take the patient for surgery. Okay, before taking the patient, you should do how will you do total anatomy? What incision you will make? What are all the steps of total anatomy?
Sir, incision.
What incision?
Sir, flexor is an incision, sir. Sir, if
Flexor.
previous tracheostomy is not done, stomal, the site for the stoma is marked midway between the thyroid notch and the suprasternal notch, sir. And then from the midline, a curvilinear incision extending along the anterior border of the sternocleidomastoid till the mastoid tip is made, sir. And subplatysmal flap is elevated, sir.
Subplatysmal flap. Okay, blood Thompson's incision is the common incision we use, but nowadays there is a lot of incisions used. You can use a skin piece incision and other separate incision for the tracheostoma, or you can use a Jackson's incision. If you do a radical neck dissection, you can use a sort of hockey stick incision or whatever it is. Okay, so if you do a bilateral neck dissection, one sternum, one mastoid process, another mastoid process, complete bringing along the anterior border of sternum-mastoid, encircling the tracheostome. You can elevate an apical flap. You can elevate the flap down, and still you can do a bilateral MRND. Okay, then if you do a only total laryngectomy, have you assisted total laryngectomy?
Yes, sir.
So once you make the elevate the diaphragm flap and fix the flap to the skin, what do you do next?
Sternocleidomastoid.
Sternocleidomastoid. You make an incision along the anterior border of sternocleidomastoid, open up the viscerovascular layer to look for secondaries. And operability. That's the first thing you will do. Check for operability. If there is a node, you do the MRND. If there is no neck node, you just proceed to do a total laryngectomy. So you elevate the investing layer. What is the first muscle you will identify and ligate?
Omohyoid.
First, you identified omohyoid at the from under the sternocleidomastoid on both sides. Then strap muscles. So you will ligate the sternohyoid and the sternohyoid, sternothyroid, and cut them. Then release them. Then what do you do next? Depends upon. Devascularize is what?
Vascular pedicles are identified and ligated, sir.
You are going to remove the you are going to remove the thyroid or not? Okay, if you are preserving both the thyroids, you anchor the thyroid on the inferior pedicle, remove the superior pedicle, and if there is middle thyroid vein, and separate it and anchor it on the lower down, so that once you finish the total laryngectomy, you can replace it. Or what you do is whenever if you suspect extra laryngeal spread, that side thyroid you got to sacrifice, remove all the ligate all the thyroid pedicle, and the opposite side you can preserve. If you suspect both side thyroid which is involved with the tumor, particularly if there is a thyroid malignancy extending into the larynx or laryngeal malignancy extending into the thyroid, then you got to do a total thyroidectomy. Okay, so you address thyroid. Then what do you address?
Suprahyoid strap muscles.
Why you want to go for suprahyoid first? You have not finished your infrahyoid dissection. What is the other attachment of thyroid to the pharynx?
Thyropharyngeus.
Thyropharyngeus muscle. So thyropharyngeus muscle, you got to dissect the muscle at the lateral border of the lateral border of the thyroid cartilage and releases superior cornu. Okay, then you identify the midpoint of the thyroid membrane for the entry of the superior laryngeal pedicle. Once you ligate the superior laryngeal pedicle, thyropharyngeus muscle, then you have the thyroid gland, address thyroid gland, cut the strap muscle, preserve the deep fascia. Once you have done that, your infra-aortic dissection is over. Then you will go for supra-aortic dissection. How will you go for supra-aortic dissection?
Sir, geniohyoid,
Lingual artery hypoglossal nerve got to be preserved, particularly when you are releasing the great run of the hyoid bone. So how do you do? So you identify the hyoid bone, all the suprahyoid muscles attached to that hyoid bone. So you separate all these attachments from the perichondrium of the hyoid bone. So if you keep separating, you will release the body of the hyoid bone, then tilt the larynx so that your greater horn is exposed outside. Then release the greater horn by hugging it. Don't go very lateral to that. Remove all the attachment, styloid ligament, styloid muscle, ioglossus, mylohyoid, all these muscles got to be released. Once you release the larynx, you will know larynx has been mobilized completely. The entry into the larynx can be done by two ways. One is from the suprahyoid area or from the lateral entry. Particularly whenever you have a tumor which involves both parts, it's always preferable to go from the suprahyoid. So how do you do that?
Sir, through the vallicula.
Okay, through the vallicula, you enter, hold the epiglottis, cut along the epiglottis, area epiglottic fold, preserve as much mucosa as possible, go close to the area epiglottic fold, but at the same time, see to that we give a good cancer clearance, good free tissues, and then joint behind the arytenoids. Once you join behind the arytenoids, you make an horizontal incision on the postcricoid area, separate the postcricoid mucosa from the cricoid cartilage. Then you, as you go lower down, you see the first or second ring according to the subglottic extension. You give a 2 centimeter clearance and then make a horizontal incision and separate the trachea from the esophagus and then release the larynx out. Okay. So once you have done that, how do you suture the pharynx?
T-shaped closures.
You can close T-shaped or you can close it linearly. How many layers you will close?
3 layers.
What is canal suture? Canal suture is box type suture which we don't practice now. Now what we do is a extra mucosal inverting sutures. So you take extra mucosal sutures, make 2 layers, 1 layer on the extra mucosal, second layer over the serous layer, and then you keep the thyropharyngeus muscle on top of that, and then you close like a subcutaneous closure. You take inside out, outside in, and bury your knot. Okay. Once you have done that, you do the
Cricopharyngeal myotomy.
cricopharyngeal myotomy. How do you do the cricopharyngeal myotomy? Put your finger inside. You just slip the finger. You see one place it's getting getting constricted. You just keep cutting with the knife so that that mucosa bulges. That means all these muscle is cut. If you don't do the cricopharyngeal myectomy, patient might have a dysphagia. Okay, so with this, you fashion the tracheostome. What suture you do for a tracheostome?
Half mattress sutures, sir.
Off mattress sutures, and you expose the cartilage got to be buried with the skin. So you take a bite on the skin, then you take extra mucosal bite on trachea, and again you take the bite on the skin. That's called off mattress, so that the skin closes the tracheostome. Okay, close it all around, and then there should not be a soft tissue between the cartilage and the skin. If there is soft tissue, the soft tissue will go for contracture, and then that will cause the stenosis. Okay, so directly the skin should be on par with that of the cartilage, and just cover the cartilage. Okay, this is called the extra. It's called the off mattress suture. Then you suture the skin, keeping two drains, both sides two drains, so that if whenever there is a one drain is blocked also, so other drain will be of some use to you. Okay, then what will you do? When will you remove? What are all the complications expected?
Sir, hemorrhage, hematoma, wound infection, pharyngocutaneous fistula.
Right tube should be inserted before surgery. Immediate complications, the post-op complications can be cardiac complications. Okay, long surgery, patient can go for hypokalemia. So always you take an ECG and serum electrolytes to look for hypokalemia. You look for UA in the ECG. Okay, then you look for the patient whether there is any lung is expanded completely, because there can be a long tube can go for a single lung ventilation, other lung can go for collapse. So you just check it up that always whether both the lungs are all expanded well. Okay, then from the second day you should do all the basic investigations. When will you start orals?
Sir, I'll skip feeding from the third day, sir.
If you keep Ryle's tube, you can do it from the third day. If you are doing outside, if you do a peg, you can start the feeding immediately. That is after 6 hours, 8 hours, you can start the feeding, because Ryle's tube goes through the sphincter. You can have aspiration, so that can contaminate the wound. That's why we give it after 2-3 days. Okay, then whenever you start feeding, you can see a increased amount of drain. That is white color fluids comes out of the drain. That is called chyle fistula. So you can give a pressure bandages, or you just explore and find the chyle duct and ligate it. Okay, then when will you remove the sutures?
Sir, neck wound sutures are removed on the alternate sutures are removed on the 7th day, and all sutures removed on the 10th day, and the stomal sutures on the 14th day.
10th day to 14th day, anything. Okay, then when will you start orals?
10th day, sir.
10th day you start orals. Look for pharyngocutaneous leak. If there is a leak, manage the leak. Otherwise, you can send the patient to the home on the 14th day. Okay, if the patient has got a neck node, what will you do?
Post surgery.
Patient with a CA larynx with the neck node, mobile neck node, T3 node, what will you do?
Neck dissection, sir. Bilateral level 2
No.
to level.
Only one side neck node. What do you do? CA larynx for a Gen 0 neck, you don't operate. Gen 0 neck treatment is wait and watch only. You don't do a neck dissection. Okay, only when there is supraglottic extension, you think of neck dissection. Otherwise, you don't do neck dissection. Okay. Tell me.
Chemotherapy.
No. You do total laryngectomy with MRND on that side. Okay. Which one you do first? Total laryngectomy or MRND?
MRND.
Always you do MRND first. Okay. So when you do an MRND, where will you remove the tumor out completely, or you will remove it along with the larynx? This will tell you whether you have seen the surgery or not. So when you do a total laryngectomy, when you remove when you finish the MRND, the MRND specimen need to be attached to that side thyroid membrane. That side thyroid membrane along with the superior laryngeal pedicle, then complete the total laryngectomy and remove the neck dissection specimen along with the total laryngectomy. Unless you accidentally cut the attachment. Okay, so you just remove, you just take it out, leave it attached to the larynx and the thyroid membrane near the superior laryngeal pedicle, complete laryngectomy, and then remove it along with the laryngectomy. So what are all the structures removed in the case of a radical neck dissection?
Sternocleidomastoid, IJV, and recurrent laryngeal nerve.
Recurrent laryngeal nerve. Accessory nerve. What happened? Accessory nerve. Okay. So if why you want to remove the accessory nerve? So there are two types of lymph nodes: jugular lymph nodes and the accessory nerve lymph nodes. So along the jugular jugular, there is lot of lymph nodes are there. Level 2, 3, and 4 are along the jugular. So you got to, if it is adherent with the adventitia, there is the possibility of a secondary tissue along with that is there. So you got to remove the internal jugular vein. So similarly, level 5 nodes are all along the accessory nerve. So you got to remove the accessory nerve also. And then why you want to remove the sternocleidomastoid? For exposure. Okay, sternocleidomastoid will prevent visualizing. So removing the sternocleidomastoid is only for exposure. Okay, if you are doing an MRND, if you are doing a radical neck dissection. So what is the drawback of removing sternocleidomastoid muscle? What the patient will develop? Nothing will happen. Patient will have only a cosmetically flat neck, that's it. Even if you do a MRND, you got to pull the muscle away and then do the dissection. So patient might have loss of nerve supply or loss of blood supply. It will go for contracture. It will go for atrophy. So you will have a inequality on the neck. Only cosmetic. Nothing will happen. Okay, if everything goes right, not that carotid blowout, but everything goes right, no movements, nothing will happen. Patient will have a cosmetic defect. What will happen if you If you remove the sternocleidomastoid, I mean, sorry, remove the accessory nerve. Patient will go for a frozen shoulder. Okay, patient will go for frozen shoulder. That if that is the case, patient develops pain along the neck, and patient will go for a frozen shoulder. What's the treatment? Physiotherapy. Okay, you got to regularly do the physiotherapy to improve the shoulder function. Okay, then what will happen if you remove the internal jugular vein?
So the lymphedema.
So removal of one jugular vein raises the brain congestion by 2 folds, and there will be an increased ICT by 2 folds. If you remove both internal jugular veins, patient will go for a increased intracranial pressure for 5 times. Okay, so it's not advisable to do the bilateral internal jugular vein removal. Okay, so for these reasons, you got to preserve these structures. Okay, so to preserving these structures and removing only the lymphoid tissue is called functional neck dissection or MRND. Okay, MRND, you have 3 types: type 1, type 2, and type 3, where it depends upon what you do, what you preserve. Okay, so I told you why you want to preserve these structures. Okay, so this is about the surgical management of CA larynx. What else you do? If the patient is going for chemotherapy, what drugs you will give? What chemotherapy you will give?
Cisplatin 5.
No. If you see this is a T3 lesion with no cartilage invasion, what do you do? Organ preservation, what do you do? Chemotherapy. What chemotherapy? What RT? What is anterior chemotherapy? What is concurrent chemotherapy? So what are all the drugs used? You give 3 cycles of these drugs. Like you give a main drugs used are all 5-fluorouracil, cisplatin, and then drugs like paclitaxel. Okay, so ceftuzimab. So these drugs will be used for the for anterior chemotherapy or concurrent chemotherapy. Concurrent chemotherapy means they will do it in the periodically. Every week they can give, or they have a plan for that. The plan changes from every center. Okay, every center they will have their own plans, but usually they give is, if it's an anterior chemotherapy, they give 3 cycles, or if there is a concurrent chemotherapy, every week they'll give 5-fluorouracil, and given particular weeks with the assessment of the sort of response, they'll give the cisplatin and the paclitaxel, right? So how much grace they'll give?
60 to 70 grays.
What is the dose? How many grays per day for how many days a week? So one, tell me, 200 rats per day for 5 days a week. 5 days a week. We give 2 days for rest, for the cells to recoup themselves, so that all the growing cells will die and all the other cells will recover. You give for 6 weeks to 7 weeks. Okay, that is, you can give along with chemotherapy, or you give the anti-chemotherapy, reassess the tumor, brand them as a responders and non-responders, then give a concurrent or radiotherapy alone. Radiotherapy alone is given for non-responders. Okay, this is about the chemotherapy. This is about the radiotherapy. So, what are all the advantages of uh, radiotherapy compared with that of surgery? What are all the disadvantages?
Organ preservation, voice preservation. Sir.
You will do the step down in staging. You give a radiotherapy, reassess, even if there is a tumor, there's a residual tumor, you can operate the patient. A tumor which is inoperable can become operable. Okay, so these are all the advantages. Disadvantages, that healing will be later. If you give a chemotherapy followed by surgery, healing will be difficult. If you do surgery first, if there is some surgical complication, it will postpone the radiotherapy. So these are all the advantages and the disadvantages of chemotherapy. Okay. Then what are all the drugs which increase the efficacy of the chemotherapy? Chemotherapy sensitizes. Sorry, radiotherapy sensitizes.
Metronidazole, hyperbaric oxygen.
Okay. Blood, hemoglobin, then chemotherapeutic agents. Concurrent chemotherapy or induction chemotherapy will sensitize the patient for radiotherapy. Use drugs like Corynebacterium power, drugs like metronidazole, levomethol. All these drugs will increase the sensitivity. Okay, so what do you think is the survival rate of the patient?
5-year survival rate 50 to 60%.
Very low, 68 to 74%. Okay, that depends, right? What are all the prognostic factors? Patient's factor, disease factor. Okay, so whenever you have a squamous disease, you have a aggressive tumors like sarcomas, you have a very poor prognostication. Then the cartilage invasion, subglottic extension, large tumor bulk. Patient who got a large tumor bulk, aggressive tumors, anaplastic diseases, undifferentiated diseases, poorly differentiated diseases will have a poor prognostic factors. Most important prognostic factor is the neck node. Single node will decrease the 5-year survival rate by 1/3. Okay, then when you treat the patient, depends upon if you give a chemotherapy, what complications patient develops, radiotherapy, what complications patient develops, whether you can complete the radiotherapy. Radiation decreases the tumor, whether radiation eradicates the tumor, or when you do the surgery, how completely you could remove that surgery, tumor margins. So all these things are all important for prognostication, right? What are all the complication of radiotherapy?
Sir, osteoradial necrosis.
Okay. What happened to the eye? What happened to the spinal cord? What happened to the secreting glands? Where the patient can shave, skin sparing. So nowadays you get a lot of good radiotherapeutic units. What is IMRT? I think you have become tired. Intensity modulated radiotherapy, IMRT. So where you take the tumor, map the tumor on the computer, that decides you how much rats to be given on all the area. You should learn about what is frontal, what is lateral ports, what is multidirectional ports, how they deliver the ports, what is the collimetry, how the LINAC works. All these things you should know. Okay, of course, they will not ask you in the exam because CA larynx is the exam question, exam case. CA larynx, you have a lot of things to ask for. So once they keep on asking asking a lot of things, that the treatment part, particularly the chemotherapy, radiotherapy part, will become they'll ask just 2-3 questions and send you off. Okay. Okay, so yeah. Aishwarya, பேசுறது கேக்குதா?
கேக்குது sir.
Okay. Janagiram?
Sir, I'm here, sir.
Yeah, Asha, I think we have come to the conclusion of the session.
Sir. Sir, 1 minute, sir. Sir is asking on.
Anto.
Yes.
It was very exhaustive. Everybody became tired. Not only the candidate. Fantastic ground rounds.
Actually, a lot of things we have not covered. We have not covered about the pre-malignant conditions. How do you manage pre-malignant conditions? Anatomy. So every time we talk about anatomy, which was so boring. So we should talk very. We should always cover a small part of everything.
No, I think this is very exhaustive, and I think these are the questions I think which will definitely be asked by most of the examiners.
It is not possible to
cover the
tell
whole
all
thing.
the
Not
questions,
possible.
but the thing is, we will tell you what are all with this you go and read what are all things you should ask. Generally, around that, if you read, it should be sufficient for you. Okay, to do a good examination.
How to do probe test? One candidate is asking.
Probe test is usually it is to find out the cricoid joint fixation. You remember we used to differentiate between the vocal cord paralysis and vocal cord fixity. So when you have a vocal cord paralysis, for example, CA larynx, it goes to the rectal laryngeal nerve and then fixating. When you move the cricoid joint, the joint will move, but the vocal cord won't move because of the nerve involvement. But when the tumor infiltrates the cricoid joint, the joint will not move. So you take a like your ear probe, long contact tip probe, and then touch the arytenoid and just move it medially and laterally, and then down and out. Then you can see that cricoid joint is fixed. That is the probe test.
Yeah, Dr. Ramya, I hope you got your answer. Yeah. It is done under LA or GA, he is asking.
I told you, I do micrological examination under GA.
Yeah.
Because I need time to look into that, touch that area, palpate that area, see whether cricoid joint is involved or ventricle is involved, and then take an angle scope, put it inside and see how the ventricle is involved. For that, for me, GA is fine. Even today in our group, we have a Tamil Nadu Government Doctors Association group. We had the same discussion. I just told them, stop, I'll finish my OP, finish my grant rounds and come for the discussion and just escape from there.
Okay, okay. No, when we used to do PG, we used to do it under local only, no?
See, we do it even nowadays. We do it from using a video laryngoscopy.
Oh, okay.
Use a video laryngoscopy, local anesthesia, take it out. But that's not the criteria. What you should do properly is you got to do a microlaryngeal examination under general anesthesia. That's the way you should do it.
Okay. So, any questions, candidates? Do you have any questions, or else is it okay that we complete? How to differentiate cord fixity and restricted mobility, sir? Elakia.
No, you see that. See, immobility is the controversial thing. In exam, there is nothing called immobility. It is mobile or not. Okay, so it is partial. There is nothing called partially mobile. If it's fixed or it is mobile, you can tell it is not as mobile as that of the opposite cord. But that's all confusing. You decide whether you want to tell this as a fixed cord or mobile cord. Sorry, what is the question?
Mobility should not be answered in the exam. Restricted mobility we should not answer.
Restricted mobility, we don't advise them.
Oh, okay.
Restricted mobility is still mobile. Restricted mobility is still mobile, right?
Can partial laryngectomy be done for this case?
This case, no. If at all we want to do, if it's a radio recurrent group, you do a supracrical laryngectomy with the CHEP or the CEP. So nowadays we don't advise doing a vertical partial laryngectomy. See, these are all the partial laryngectomies are all for the early glottic cancers, not for the advanced glottic cancer. So now they do all these surgeries in an early glottic cancer or a part of TLM.
Now, suppose you have a transglottic growth,
yes.
Which area it's arising from? So the question from, I think, Ilakia. Yeah, how do you find out which area it's coming from?
Already I told her, that is when we see the growth on the vocal cord, and then it enters into the transglottic area. Most probably it starts on the as the glottic growth, like this exam. Okay. But if you see a small bulge in the ventricular band, completely upsetting the view of the vocal cord, you see only a small edge of the vocal cord and a small tumor coming out from that bulge under. And then you see that fixed node and fixed cord, then you think it is the ventricular band coming down.
Okay. I hope Professor Anthony answered your question. Does it change the management based on epicenter of the growth? Akriti.
Smaller tumors, early tumors definitely is. Later tumor doesn't matter because we take the tumor as a transglottic. When there's a transglottic tumor, whether you are going to an organ preservation or surgery or palliation, that's all.
Okay, I think we had an exhaustive lecture on grand rounds on CA larynx. I think next, now what is the next topic? Hypopharynx. Hypopharynx. That will be there next Thursday, right? Thursday and Friday.
Thursday.
Okay, so thank you, Professor Anthony. It was a pleasure. I was hearing like a student. I was sitting and trying to answer some of your questions. And I was happy that I could answer and I can at least get a pass. Thank you very much. Actually, you are propagating knowledge in a very, very big way. I'm sure it's going to help a lot of postgraduates. I'm sure they'll tune on to our YouTube channel, T and Janakram, and you can watch Professor Anthony's grand rounds. So thank you, Professor Anthony, again, from my heart, and all the students, they will convey their thanks. Thanks to you for doing such a good service. Thanks a lot. And
Ram, I am a postgraduate teacher for the past 20 years, but only after it's your brainchild that we are doing this grand rounds, and it was very useful for all the exam going postgraduates throughout this part of the world. So actually, I should thank you, which in this never struck me for all these years. I used to take class for my postgraduates, all 6-10 postgraduates here, but to make it useful for all learning fraternity is entirely in your brainchild, and you are this thing. So thank you very much. I told you, you are a congenital chronic teacher. So all the more that's not
You're going to another meeting now. Are you going to another meeting now?
Me, no.
You said you're going to another meeting?
No, I'm not. I didn't say that.
That Chennai group, doctors group meeting.
No, that is WhatsApp.
Okay. Thank you, Professor Anthony. Thank you. And I'm sure that you would have all have learned a lot of things, how to answer, and you categorize the answer, as he says. So very, very nicely, answered by the candidate also. Thank you very much. Big thanks. Thanks a lot, and good night, and God bless.
Congratulations to Aishwarya. She was fighting with everyone that she should present today, and then she did it.
No, Aishwarya did a great job. Aishwarya did a great job. Actually, she, I think, how many days now? For 25 days since she has delivered a baby. Huh? How many days?
It's 20 days.
20 days since she has delivered a baby, and she's, oh my God, really, really great. You have got great students, Professor Anthony. You are blessed by God. Thank you very much. Aishwarya, you did a great job. I was listening to all your answers. You are very well read. And I'm sure that you're going to come out with flying colors. MMC is, yeah. Thank you.
Thank you, Harsha. It was
thank you, Harsha.
Nice arrangement.
Thank you, sir.
Harsha is always there. When academics is there, Harsha is there. So it's like that.
Sir, thank you, sir.
Yeah, thank you.
Thank you.